Welcome to the Physiological Reports podcast, which highlights articles published in the journal. I'm Larissa Shimoda, an associate editor for Physiological Reports. Today, we're discussing a recently published manuscript titled "The Tyrosine Kinase Inhibitor Imatinib Prevents Lung Injury and Death After Intravenous LPS in Mice" by Scott Stevens, Laura Johnson, Laura Savinsky, Bo Kim, and Mahendra Damarla. This study examines the effect of treatment with imatinib, a commonly used cancer therapeutic, also known as Gleevec, on outcomes in a murine model of lung injury and sepsis. I'm joined today by two of the study's authors, Scott Stevens and Mahendra Damarla, both assistant professors of medicine in the Division of Pulmonary and Critical Care Medicine at Johns Hopkins. Scott and Mahendra, thank you for joining me to discuss your work. Tell us a little bit about your study.
Thank you, Larissa, for giving us the opportunity to be on this podcast. So in previous in vitro and ex vivo work, we had found that activation of protein kinase G, or PKG, attenuated pulmonary endothelial oxidant injury by increasing endothelial levels of the antioxidant enzymes catalase and glutathione peroxidase in a post-translational fashion. Now, interestingly, both catalase and glutathione peroxidase are regulated post-translationally by the c-Abl tyrosine kinase, which is what imatinib inhibits. So we next decided to look at the effect of PKG on c-Abl activity. We found that activated PKG inhibited c-Abl, and correspondingly that inhibition of c-Abl, both pharmacologically with imatinib and with siRNA, mimicked the antioxidant effects of PKG activation. In the present study, we hypothesized that imatinib would protect the intact mouse from a clinically relevant injury. We used intravenous lipopolysaccharide, or LPS, as a model of endotoxemia mimicking gram-negative sepsis, which is a common cause of acute lung injury and the acute respiratory distress syndrome. LPS exposure induces reactive oxygen species, or ROS, which are thought to contribute to the pathophysiology of LPS injury. We pre-treated mice with imatinib via oral gavage or placebo for 24 hours and then injected mice with IV LPS. Our data show that mice pre-treated with imatinib demonstrated decreased markers of lung oxygen injury, decreased lung apoptosis, and decreased pulmonary edema. Systemic cytokine levels, which are markedly increased after LPS injection, were significantly attenuated by imatinib. Finally, and most notably, whereas 90% of control mice died by 72 hours after LPS injection, all imatinib-treated mice survived exposure to LPS.
There are many instances reporting that oxidative stress is a main component causing damage and lung injury. And I was really intrigued by your finding that imatinib was protective, but had no effect on oxidant production. Given this scenario, do you have ideas as to how you think imatinib might be working?
Hi, Larissa. This is Mahendra. Actually, we think that imatinib confers its protection, at least in part, by increasing endothelial oxidant defenses. We actually found that IV LPS induced a significant increase in xanthine oxidoreductase, XOR. And what's important is that XOR is an important source of reactive oxygen species in response to IV LPS. Imatinib pre-treatment did not affect LPS-induced increase in XOR activity, but rather, imatinib caused a significant increase in lung catalase activity. So we actually believe the injurious ROS are not themselves decreased. Rather, treatment with imatinib increases the cell's intrinsic protection against oxidant injury. This increased protection prevents cells from experiencing oxidant-induced DNA damage and oxidant-induced apoptosis, and decreases in permeability of the endothelial barrier. There may be other protective mechanisms by which imatinib is working, and other groups have reported that imatinib improves pulmonary endothelial barrier function after exposure to a variety of injurious stimuli, including non-oxidant injury. There's also a question of whether the protection against mortality afforded by imatinib is wholly due to decreased lung injury, or whether the decreased levels of cytokines after imatinib pretreatment reflect a decreased systemic inflammatory state. But we're hoping to test these hypotheses in our lab down the road.
I think your study is a nice example of preclinical work exploring repurposing of already approved drugs. In thinking about translation to the bedside, what do you think are the clinical implications from your work?
With Scott again, Larissa. We think the clinical implications are potentially quite significant. Despite years of work, there are no specific therapies for human ARDS, or for that matter, for sepsis. Treatment is purely supportive. As you noted, imatinib is already approved for use in humans and has a long track record and really quite good safety profile. And we think that our work and the complementary work of other groups provides a strong rationale for the testing of imatinib as a novel pharmacologic agent in the treatment of ARDS. Now, while our data is suggestive for a potential role for imatinib in treating gram-negative sepsis-induced ARDS, we actually feel that investigating the role of imatinib in the treatment of non-infectious causes of ARDS would be an ideal first step. If you include both infectious and non-infectious causes, that inclusion can lead to a more heterogeneous population and may make it more challenging to determine the true effect of the therapy. By limiting an initial study to non-infectious causes, you would A, be preventing any heterogeneity that comes in just from different types of infections, but also potentially attenuating against any potential inhibitory effect of imatinib on necessary oxidant production, meaning the reactive oxygen species that are used to kill bacteria. So we think that potentially using imatinib in a non-infectious model may be the ideal first step. We do admit, though, that more preclinical work clearly needs to be done to evaluate imatinib effect not only in non-infectious causes of ARDS, but also in infectious causes.
Scott and Mahendra, thank you for joining me today and discussing your exciting work. We look forward to seeing more of your studies and physiological reports.
Thank you for having us.
Thank you very much.